Good morning, everyone. Myself, Nikki. I am second year PG resident from Safdarjung Hospital. I'll be presenting case of proptosis with triradiate spread. A 48-year-old male presented with complaints of autoprotrusion of right eye since 4 months, which was insidious in onset, gradually progressive, associated with mild pain and redness, and associated swelling of right side of forehead. There was no history of any diminution of vision or double vision, no increase in protrusion on straining or cuffing. There was no significant past history or family history, but he had a history of tobacco chewing for the last 30 years. On general physical examination and systemic examination, no specific findings were noted. Coming to ocular examination, his best corrected visual acuity in right eye was 6/6 parts, and in left eye it was 6/6, with normal color vision and contrast, and slightly elevated intraocular pressure in right eye. Kastenbaum's limbal motility method showed limitation of movements in right eye in all gazes, with dystopia of 11 mm in vertically downward direction and 5 mm in horizontally outward direction. Hertel's exophthalmometry showed significant proptosis in right eye. On inspection, Napziger sign and Worm's view showed asymmetry with right cornea appearing first. There was abaxial proptosis in down and out direction. We could see right subbrow fullness and diffuse swelling over right subbrow area, which was extending to forehead and temporal fossa. There were few dilated veins. Lagophthalmos of around 3 mm was noted. There was no erythema, discoloration, sinus fistula, no visible pulsation or an increase in proptosis on bending forward or Valsalva maneuver. An ill-defined firm mass in right subbrow area was present, which was extending to temporal fossa and forehead. It was immobile, fixed to underlying structure. Fingers could not be insinuated. It was non-tender with normal temperature, non-reducible, non-compressible, with no palpable thrill or pulsation. Coming to anterior segment, in right eye, there was diffuse congestion, mild chemosis, and few prominent episcleral vessels were present. Rest of the anterior segment in right eye and left eye was within normal limit. In posterior segment, few choroidal folds were seen in right eye. Rest of the findings were within normal limit. This is depicted in this diagram. To summarize, a 48-year-old man came with the complaints of autoprotrusion of right eye for 4 months, with swelling in right subbrow area, right forehead extending to the temporal fossa, which was gradually progressive, associated with mild dull aching pain. On examination, his vision was spared with normal color vision and contrast. There was abaxial proptosis and dystopia with limited extraocular movements. There was diffuse congestion, chemosis, and prominent episcleral vessels and few choroidal folds. On the basis of our clinical history and examination, our differentials were lacrimal gland carcinoma, sphenoid big meningioma, osteosarcoma, and metastasis. Routine investigations were done, which came out to within normal limits. On imaging, contrast-enhanced CT scan was done, which showed triradiate spread, that is, intracranial spread, as we can see in this picture, intraorbital spread, and temporal fossa mass. Bone window showed frontal bone destruction. Our next step was incisional mass biopsy, which was done, and few pieces around 3 to 4 mm was cut out and sent for histopathological examination. This is the picture of patient post-op day 1 with sutures intact and dystopia. On his histopathological report, tumor cells were arranged in gland ducts and cords with atypical mitosis. Cells were positive for pan-CK, CK7, P63 with high Ki67 proliferation index. The features were suggestive of primary ductal adenocarcinoma. As this was a case of metastasis with intracranial spread, multidisciplinary approach was taken, medical onco and neurosurgery opinion was done, PET scan was advised, and palliative therapy was considered. Few words on our case. It is an aggressive tumor which constitutes 3% of malignant tumors of lacrimal gland. Mean age at presentation is 60 years with slightly male predilection. Most common presentation is palpable mass, proptosis, and pain. It has poor prognosis and high mortality. Take-home message from this case is proptosis with triradiate spread may be presentation of many diseases like sphenoid big meningioma, lacrimal gland carcinoma, metastasis. Multidisciplinary approach is the need of the hour. A simple biopsy can be life-saving, as definitive diagnosis can be made on histopathology. Thank you.
After getting the histopathology, what did you do? I missed on the slides. After getting the histopathological diagnosis of adenocarcinoma, what did you further do?
So firstly, we advised patient to get a neurosurgery and a medical onco referral as it has intracranial spread and medical onco
It was a localized intracranial spread, na?
but
Just
the frontal bone was totally destroyed,
yeah.
and on doing biopsy, when we were taking bits and pieces from the mass, it was very friable and there was like extensive bleeding from the mass. So we didn't do the debulking during this incisional biopsy, and we didn't plan for like exentration and anything because it has an intracranial spread.
What did your neurosurgeon say?
Neurosurgeon people say it can be like excised, but the prognosis was very poor, and patient came from the poor background. He didn't want.
And what about the radiotherapy department?
Radiotherapy was advised, but patient didn't follow up. Because of the poor prognosis, he didn't follow up and lack of the family support.
During follow-up, you don't know what happened. It didn't come back to you.
He was under follow-up for 2 to 3 months. When radiotherapy was advised, his family support they took back because of the financial crisis, and he literally went without follow-up.
Actually, your case could have been very good if the further follow-up and treatment.
Yeah, because of the patient constants, we couldn't follow up this patient.
Diagnosed and left the patient, and straight away a treatable lesion has been made to go to the category of palliative.
Because of the patient contracts.
It was not to the extent that patient needs palliative care as of now. Could have been managed well.
It's from Safdarjung Hospital,
Yes.
na? There are some Pradhan Mantri course Yojana and all, which does help these poor patients. So if you could follow up, probably they can be helped out. In AIMS, it's Pradhan Mantri course Yojana for very, very poor patients is working for years and years. So
yes,
that way
we have counseled him about this, but the literacy and the lack of the family support was hindrance. मैंने सर बोला भी था एम्स चलाओ, but